Good morning, Mr. Casper.
Good morning, my lord. Our witness this morning is Susanne Napier.
Good morning, Miss Napier.
Good morning, Lord.
Shall I begin?
Please.
Good morning. Would you tell the inquiry your full name, please?
Susanne Anderson Napier.
And I believe in relation to the inquiry you've provided a witness statement, is that correct?
Yes, it is.
And the witness statement, the top of the witness statement will appear on the screen. You've signed this witness statement, and before you signed it, had you read through it?
Yes.
And are you content the content of the statement is true?
Yes.
And do you wish to adopt all of that statement as part of your evidence today?
Yes, I do.
For our records, the witness statement number is SCI WT 0472, then 5 zeros and 1. Okay. I'll ask you this, from which organisations are you appearing this morning?
Turning Point Scotland, Unite the Union.
Right, so,
Unite the Union.
Yeah, and is it correct to say that effectively you had two roles during the pandemic? One was your employment with Turning Point, and I'll ask you to explain that in a bit of detail later, and secondly for Unite the Union.
Yes, that's correct.
And tell me about your role within Unite.
My role within Unite is I'm a workplace rep. I'm also the treasurer and the secretary for the branch, which is SC38/415.
Yours is an organisation which loves acronyms as well. In terms of Turning Point, do you know how many staff, how many employees it had?
Yes, it's approximately 1,600.
Okay, and over what range of roles does that organisation operate?
Do you mean in terms of the individuals they support, or do you mean...
No, what do they do?
What do they do? They support vulnerable individuals in society.
Right, and in your role, what was it you specifically did?
My role as lead practitioner means that I supported individuals in the service known as Time Out Stroke 218 service, was to support individuals in the criminal justice system, women who had offending behaviour.
And in what venue did you provide that support?
That was 218 Bath Street, the service known as Time Out, or 218 as it's, you know, more people know it as the 218 service. Right. Criminal justice.
And I understand that that service no longer operates, is that correct?
Yes.
Okay, I'll ask you about how it came to an end, if I can put it that way. But whilst it was operating, what function did you carry out? You said you were a lead practitioner.
Yeah.
When did you work?
When I first started there for about a year, I worked in the day service, the day shift team, and quite quickly, as about a year in, that would be about 2014, I started working night shift. So I was the lead practitioner on night shift. There were 2 staff on night shift, myself and a support worker, and basically it was to, you know, support the women throughout the night. It was a 24-hour service.
Was it a residential service?
It was a residential service at that particular point. There would be 12 beds, so there'd be 12 women. We were generally, you know, pretty often full. Be 12 women with, as I said, they had offending behaviour, offending histories, but most of them, and I would say 90% plus, also had issues with substance misuse, both alcohol and other substances. So when they come in, they would be undergoing detox, and at night I would be supporting individuals through that process. You know, emotional support, homely remedies. We had nurses on board, but not throughout the night. Really, all aspects of supporting folks to emotionally and physically.
And was Turning Point viewed as an alternative to custody?
Yes, this service in particular came about as a result of an increase in suicides in Corton Vale Prison, and following a review, it was decided that we needed something different. We needed a more holistic approach, something that was less punitive. So 218 was, you know, basically conceptualised to do that, providing, you know, holistic support, you know, counselling, cognitive behaviour therapy, detox from alcohol and other substances, group work, emotional support, just a more holistic and just a better way of supporting folks, because most of the women there were really victims and had been since their, you know, their younger years.
Okay. Are you able to tell us what the budget for the 218 was when it was up and running?
Yeah, prior to COVID, it was actually 2 million was the budget. Shortly after COVID, they reduced that by, I think at that point, I think they reduced it by 200,000, and that took away the day service. In addition to the residential service, the 12-bedded unit, we had a day service that supported around 60 women in the community from Glasgow and Greater Glasgow. But that budget at that point was slashed, and the reason for that was that we weren't getting the same footfall. However, considering we had just gone through COVID, which had an impact on who was presenting at the service, that's why that budget at that point was reduced to 1,800, you know, 1.8 million.
Now, we've heard from a number of different sources that third sector organisations often have to bid for funding from government agencies, health and social care partnerships, or from Scottish Government. Did Turning Point, did 218 go through a requirement to bid?
They did just last year, but or rather, no, this year. Prior to that, no. Our funding was came from a different budget. I think it was from Justice budget, central government. We didn't need to put out tender. The money was there pretty consistently until this year, when you know, we had to put it out to tender.
And having said the budget previously was £2 million, how much would the bid have paid a successful bidder?
Or how much were they? I'm not quite sure what you mean by that, but if I could, what I will say is what happened was there was a review of services carried out in I can't remember the exact date. There's a review of services carried out, and we were asked to put in a bid for it.
Can I take you to paragraph 7 in your witness statement?
Yeah, right, okay.
And you say there about the cut in funding, and then decision was very controversial.
Yeah.
Funding for the facility was put out to tender.
Yeah.
With the outrageously low budget of 600,000.
Yes, that's right.
Having put it out to tender with that as the budget, did anybody bid?
No, and as I've said in the statement, I had to backtrack on that there. It was, they have originally said our budget would be, I I think they were saying it was going to be 12, and then just immediately they came out and slashed it to 600,000, which is a completely unworkable sum. When you consider it had been 2 million reduced to 1,800, so that's when we took away the day service. So 1,800 was the amount of money we required to run the 12-bedded unit. And when you consider that the tender that was offered was 600,000, it's completely unworkable. You know, it was 1/3 of the money that we had after the initial cut
And
back in 2020.
What was the impact of that on the service?
Well, the service had to close because nobody bid. Turning Point knew that they could not even dream of running that service on that amount of money. It would actually, if they'd run it on 600,000, it would have been a hostel with no support. They wouldn't have had all the support. I mean, we had doctors, nurses.
But that decision was taken, and was that decision taken independently of COVID? Or did COVID impact on that?
Well, I suppose that's a matter of conjecture, isn't it? Because,
Okay.
you know, we have different ideas about why they were trying to claw back finance. A lot of people might have said that because funds were so low following the cost of COVID, they were trying to get money back in whatever way they...
So now now that 218 has closed,
it's gone.
what are you doing?
At this point in time, I'm just in between jobs, although I still work as what's known as a companion for Unite. I'm due to start another job shortly, but at this point in time, I was made officially redundant on the 31st of March.
And what's your new job?
I'm a stand-down officer with Unite the Union.
So a full-time official? Well,
A part-time, full-time official.
a part-time, full-time official. Okay. Now, at the start of COVID, the lockdowns, I understand you were off work. Is that correct? Yeah. And I understand the reason for that is because you personally suffered 2 bereavements in quick succession.
Yes.
I don't want to go into the details of those, but the consequence of that was that you were off work, as I understand it, until, when did you go back?
August, beginning of August,
Okay. So
2020.
Right, so you were unable to work. Did you carry on any duties or functions in your capacity as a union rep?
Yes, I did. I continued to take calls from colleagues.
And what did you do with those calls when you were receiving them?
Some of the calls I was able to just deal with at source by allaying people's anxieties, or, you know, point them in the direction of policies that had been put out by Turning Point Scotland. I was privy to them still.
I also understand that you would refer quite a lot of people on to a particular individual within the organisation. Now, please don't name that person, but can you tell me what their role was?
The Health and Safety Officer for Turning Point Scotland.
Right, and how were they dealing with inquiries they were receiving?
It's my understanding they would be gleaning the information from the same of, you know, from what government was putting out, and they would then be passing that information back on to their, you know, colleagues, people that they were supporting.
Right. Can I take you to paragraph 17? And you talk there about what the calls were about, and you indicate they weren't really about PPE. Was that because within the organisation, PPE was pretty widely available?
Yes, it was.
And then at 18, you talk about most calls from people working in the learning disability sector. Can you tell me about that?
Yeah, really, as I said, most of the calls I received was from that particular sector because they had they felt they had less control over the hygiene and who was coming in next to the project or who was leaving, whether they had cleaned it properly, and also there would be at times relatives visiting. You know, I know that there'd been a restriction on that. But the anxieties were around people coming in, maybe not social distancing, maybe the place was not as clean as they would like it to be. It was just a general anxiety around transmission. Right. But most of the inquiries came from that particular area.
And at 19, in the witness statement, you talk about people being concerned about going off sick.
Yes.
And people approaching you as a union officer in relation to that. Can you tell us about that?
Yeah, as I said, folks were concerned that if they were off sick, would that be a trigger point? Would that then mean it would result in formal absence, disciplinary procedures? And I was able to tell them that no, that we had come to an agreement that that would, you know, any COVID sickness absence, although that would receive support to, you know, to see how they were and whether they were fit to return to work, it wouldn't result in disciplinary action at that particular point in time, that they would be supported and also paid.
Mm-hmm. And you move on at paragraph 20 to talk about changes to the guidance happening all the time. Mm-hmm. Tell us about that and what impact that had.
I suppose that, you know, that's quite an anxious period of time because there was so much stuff to try and read through to keep abreast with what the current procedures were. You know, it just felt as if there was information just cascading from everywhere, from the union, from Turning Point Scotland, from the government. You know, a bit of a whirlwind going on really to try and keep abreast with the information that then I would have to pass on to others.
Mm. Now, you have a heading just before paragraph 22 in the witness statement, which is daily routine within the facility. And what you're talking about there is the normal practice prior to COVID happening within the facility and how 218 engaged with residents in particular. I don't need to take you through that kind of daily routine, but you at 29 talk about having to incorporate social distancing into the daily routine. Just tell us about that, please.
Well, it meant changes to the staff team. You know, we had quite a healthy staff team, you know, and healthy as in terms of numbers, and that had to be reduced to ensure that, you know, we were not, I mean, there was a narrow corridor, you know, you'd be sliding along the walls to try and maintain social distancing. And also for, you know, when the shifts changed, there was also a change to that where the handovers were different and also how we engaged with like nursing staff. Normally I would go in with the nursing staff and with the women and sit and chat, but that no longer happened. We were just given, you know, handover by one person in a room, isolate, you know, seats, you know, socially distanced. It was difficult because people would forget, especially the women that were using the service. They would forget and come right up to you and ask you things, and you were trying to say, you know, please, you know, can you maintain a distance? It was just a very, very, very difficult time. Everybody was so anxious about transmission.
You indicate, and I don't need to take you to particular bits of it, but from 22 to 28, the activities that would normally be involved for women. Tell me about the activities for women residents when COVID happened.
Some women chose to self-isolate and they would be in their rooms for most of the time. We had a lounge area, a pretty big lounge area, which folks could access only two at a time and socially distance. Really the main thing that they did was probably watch TV. They had more access to laptops to allow them to engage with family. Prior to the COVID, the families would visit regularly, you know, a supported visit with staff there, but they would visit regularly. Folks had children, you know, women that used the service had children, they would visit, they could no longer see their children, so they did that through, you know, FaceTime, that sort of thing. They were incredibly bored, that's what I'll say, you know, and isolated. Part of the thing that they needed most was support from other people, and really that couldn't be provided in the way it had been prior to COVID.
Okay. Now you talk about at 31 the COVID outbreak and lockdown, and then you provide personal information as to why it was that you had to take time off work, and as I've said, we don't need to go into that. But at 33, you talk about the facility also doing work in the community. Can you tell us about that, firstly, pre-pandemic?
Do you mean my role?
Or
just the service?
The facility.
Well, the facility, as I said, had a day service which supported women in the community. So it ran groups, it ran group work, a group work programme, you know, the group work programme would be about offending, about addiction, mental well-being. There would be craft groups. There was an acupuncture offered daily, acu-detox. All of that ceased. All of that stopped.
Okay, and then we know that you had a period of absence until August 2020, and you talk about that at paragraph 35. And you talk about some of the changes that you've already made reference to. Is there anything in paragraph 35, particularly the final 4 or 5 lines, that you want to talk about? You're talking about women suffering a relapse whilst they were in. How was that dealt with during the lockdown periods?
Well, some women would just leave the service, and that would be that. They would just go and back out onto, you know, some folks had nowhere to go. They would be back out onto the street. But I think just the pressure of being isolated and not really, although they were still receiving a degree of support, it was not the support, nothing like the support that they received prior to the pandemic. You know, not only did they not have support from staff, you know, they didn't have the support from their, fellow residents. It was no longer available, and part of the recovery process is building community support, as in the community of 218. That was no longer available to folks. So for some folks, relapse, it just seemed the only way that they could cope with their mounting anxiety was to go out and possibly use substances, drink alcohol. It was a very, very difficult time. Very difficult.
How did Turning Point respond to that?
There's really not that much that Turning Point could do. We could try and find people once they left. You know, we always had contact details, mobile numbers. Some folks had no address to go to. But what we would do is we would contact the police and tell them that such and such individual had left the service, or if someone had been sent there with a court order, you know, through their lawyer, then obviously we would contact the relevant individuals and let them know that, you know, someone had just sort of left, and we would hear an alarm sometimes. Folks would just leave in the middle of the night, down the back stairs, gone. It was really difficult because there was nothing out there for folks.
At 37, you talk about health and safety, and again you make reference to the health and safety officer and also the chief executive, but you also give an indication about another anxiety that staff had in relation to transport.
Yeah.
And you would hear, did you hear about that through your role as a union official, or was that something you just picked up?
Probably both. People would talk about that in the context of, you know, other calls, and in addition to this is how I feel about it. I have to travel to work. In fact, it was something actually I had to do myself, so I can personally relate to that fear of transmission when you were on public transport. You know, I travelled over an hour to work and an hour back, so sometimes you were in closer proximity than you would have wished to be. So I would say both folks were just talking about it generally, staff, and then other folks would be mentioning it, as well as, you know, difficulties around, you know, their work-related stuff.
You've spoken about the necessary support within the 218 community, if I can put it that way. As a worker, were you also getting support from the wider Turning Point staff? Was there any communication, staff communication, across the organisation?
Not that much.
And what about in terms of dealing with guidance? When new guidance came out, how were you as a staff member, and quite a significant staff member, effectively running a shelter during the night? How were you provided with information regarding updates to guidance?
Regular, very regular contact through email from both the chief executive and the health and safety officer. They were cascading information very often, and if need be, I could pick up the phone at any point and call the health and safety officer.
Was that guidance always consistent with itself, if I can put it that way? You know, did it change significantly over time?
Yeah, and that's why there were regular updates.
One of the complaints that we've heard from other sources is that the guidance that was being issued was too frequent and and not always consistent with previous guidance. Was that your experience?
Yes, there was really a plethora of information, and it was pretty hard to keep up with it. And yes, it was changing often. You know, people were saying, "Oh, I've just read such and such," but you know, now they're saying this. And it was just a very, very difficult time. It was a pure upheaval to not only our personal lives at home, but you know, in the workplace. Yeah, very difficult time.
Okay. I'm going to go back. I just want to clarify something. The funding that you received, was that from the criminal justice system within Scottish Government?
Yes.
It was. But
there was also a ring-fenced amount that we had, and I think it might have been £300,000. There was a ring-fenced amount that came from the City Council, which was withdrawn. They said they could no longer afford to do that, and that ring-fenced amount had been in situ since, well, that would be, when did that open? 20 years this year, so it would have been in 2004. So that amount was available, and then it was just withdrawn.
Gone. And at 45, you talk about the process for women who going through the process. So how women came to end their time at 218. How long typically would a woman be in 218? Typically.
Well, prior to COVID, it would be 6 months. after COVID and towards the end of the service, it was, whittled right down to 16 weeks,
Right.
which is not nearly enough time.
And tell me about the transition. I mean, what happened at the end of the period that a woman would be with 218?
Towards the end of the period, the women would go through a process called graded exposure. And what that would mean is there'd be a plan, a risk assessment plan put in place to start the gradual process of people moving back into the community. So that would be in terms of them dealing with how they felt emotionally, being outside the safe environment of the building. So, as I said, a plan would be put in place, and initially we would support individuals to go out, maybe just have a coffee, whatever, return to the service, and that would gradually improve until someone had a plan of action that they would follow. You're going here, you'll have a coffee here, you've chosen to maybe go to 2 different shops, you'll go to this shop, you go, it was quite prescriptive. You stuck to the plan just to enable folks to gently return to society without just saying, there you go, you're back in Circuit Hall Street. And
was that a supported process?
Yes,
and who was it that was providing the support?
The day service staff, the staff that worked the day shift, not the day service, rather the day shift staff would provide the support, carry out the risk assessment, formulate the plan in an agreement with the women.
And at 48, you talk about referrals and how the process for referrals changed over time, and that the geographic area was reduced. Can you tell us about that?
Prior to COVID, and possibly I can't remember exactly when it changed, sometimes between the COVID and now, we used to be able, our catchment would have been Greater Glasgow, Scotland. We would have women from all over, and then that was reduced down to city, Glasgow City. So we couldn't take referrals from South Lanarkshire, North Lanarkshire, Renfrewshire, etc.
Which you had been taking previously.
Oh, absolutely.
And was the service that you were providing highly regarded by the users?
Absolutely.
Yes.
Absolutely.
You talk about that, you talk about something quite surprising in relation to that, at paragraph 48, about halfway down, where you say that the criteria for entry was to have a conviction. Tell me about that.
Previously, we had supported women who were at risk of offending behaviour, and also at risk of getting a criminal conviction. So we would support individuals to see where their behaviour was leading them. And then afterwards, what we had to do was take women only who had an existing criminal justice history. They already had convictions. And I think I said that some women had actually said that they'd gone out and committed crimes so that they could get into the service, because they knew if they hadn't been charged with something, they didn't have a chance of getting in the service. And I found that was, we had been proactive, and then afterwards, it was a reactive service. We were supporting women who had actually a criminal justice history, as opposed to be at risk of offending, which is a much better way of dealing with things.
At paragraph 51, you talk about the number of calls that you received. Now, presumably these would be calls from fellow trade union members. Can you just tell us about how that varied over the period of COVID?
You've said it, it was not only from trade union members, it would also have been just probably from Turning Point Scotland staff as well, people who I was supporting, people who weren't members. I'm not going to say I just wasn't going to say to someone, no, I'm not supporting you, you're not a member. So I was taking calls really from the whole staff team
And
at
you
that
explained to
point.
some extent what the calls were about. Can you tell us about that?
Again, I'm asking about just trying to allay their anxieties around sickness absence, about, as I already spoke about, the learning difficulties service, where it was around the hygiene and it was about transmission, about folks coming out of, you know, people who had. I did say earlier in the statement that Turning Point Scotland doesn't support elderly people, but we support elderly people who have learning difficulties. So they would have been in and out of being more vulnerable through age, and also having the, you know, Down's syndrome, whatever learn. It meant that they did get a lot of hospital treatment and may have been in hospital, and quite a few calls were around someone getting out of hospital and coming back into the community to share a house with maybe 3 other individuals and workers. So folks were at their wits' end saying, oh, the hospitals are full of COVID. What happens when they come out? Do they have COVID? Do we test? There was a lot of anxiety around that.
And did Turning Point take steps to allay those fears?
Yes.
Why were people coming to the union rather than to their employers?
Probably just because they thought maybe they had more, not confidence, but just maybe I'm more approachable. Or they felt I was more approachable. There to.
And at paragraph 53, I'm not going to ask you to read it out, but you identify that there were particular problems at particular facilities.
Yes.
Again, without going into the specifics of what you refer to at paragraph 53, what was different about the venues from which you were receiving a large number of calls?
Those would have been the services which were in people's own homes. So what there would be is maybe a 4-apartment house supporting 3 individuals living in their own home, shared accommodation. And that would have been, as I said previously, about maybe folks being in hospital, coming out, back into service, and also the amount of staff that were going in. So you would have maybe 2 staff in the morning, 2 staff in the evening. You might have 6 staff supporting those 3 individuals over a 24-hour period. So it was just about the footfall, the amount of people, the social distancing. They were definitely in much more close proximity. So the anxieties were just around transmission.
And you refer at paragraph 55 to you being involved in communication with managers about people going off with COVID. Mm-hmm. Again, why would you be involved in that rather than someone just going directly to their line manager?
Because at times the line managers appeared not to be aware that there had been an agreement made that folks wouldn't be penalised for it. And the letters that were being sent out to individuals who had been off sick with COVID, the letters at that point still had headings like formal absence meeting, and people were saying, why is this a formal absence meeting? I've had COVID, it shouldn't be like that. So I was then going back to managers and saying, look, can I refer you back to, you know, probably the communication that you've had from X, Y and Z, because it's clearly saying this shouldn't be a formal, this is not a formal absence meeting, it might be a supportive meeting. Mm-hmm. So you need to, and they did eventually change the wording on that. Mm-hmm. And that created a lot of anxiety around folks, you know, this formal, you know, absence. People thought, oh, lose their jobs, they won't get paid, blah, blah, blah.
At 55, you talk about workers who were off several times with COVID in close succession. Did that lead to particular anxieties?
Sorry, which paragraph are you referring
55.
to? 55 again. Mm-hmm. Yeah, of course. There were, you know, there was an anxiety around it, but although those procedures did change, I know more recently the COVID, anyone who's off with COVID, it is now just as in sickness absence at that particular point in time, it wasn't. So I was, again, just saying to them, don't worry about it. Do not worry about the, you know, your absence through COVID. If you can prove that you had COVID, you will be supported. You'll be supported through that. You'll receive your wage. You won't be penalised. You'll get a supportive meeting, but it's not a formal absence meeting. It's just, it should just be a supportive meeting. And it's really down to, I would say, the ineptitude of some of the managers who maybe weren't reading, you know, are not getting properly briefed on what they should be doing.
Right. Paragraph 59, you talk about a longer term impact within not just Turning Point, but the health and social care sector in general. Can you tell me about that, please?
Yeah, and you see, but you know, my first kind of statement in that, I would say a lot of people who were definitely worked harder, had more anxiety around their own health and providing support for others with wages that didn't reflect what they were doing, just thought, we've had enough, we're leaving this sector. And we're still feeling the impact of that now.
So, did you view that as quite a significant number of people who simply said no more?
Yes, yes. And we know in Scotland that there is now, you know, the social care sector is on its knees, basically. There have been so many people that left and just said, no, we've had enough. And I know it's probably similar in the NHS. It was such a stressful time for people, and they just don't feel they were, you know, although people were out clapping in the streets, you know, they weren't financially remunerated. They didn't feel, they felt after it was all sort of dying out that they just went back to being kind of dogs' bodies, really. That was what the people would say.
62, you talk about what you view as a difficulty that arose from wearing masks.
Yeah, without a doubt. I've never in my life ever had sinusitis before, and I had it really, really badly, and still at times suffer for it because I had to wear a mask. Wear a mask on the bus, 2 hours, wear a mask for a 12-hour shift, unless I was sitting on my own. Yeah, I feel that had a real detrimental effect to myself, and I know that there are even people within my family are suffering from it, regular sinusitis now. And that's what they, you know, I suppose having a mask on and having the fibres had an impact. And my daughter's a nurse, her face would be red raw, literally, with wearing a mask all in a heated environment.
Paragraph 63, you talk about your attitude to the vaccine. I'll give you the opportunity to explain that.
Yeah. I do believe I have long COVID, and whether, I mean, I'm not a microbiologist, I haven't studied it in depth, but I do know, and I do feel that the vaccine came out so quickly, and although, of course, there are, you know, they've done various studies prior to it, you know, COVID-19, on the one hand, they were saying it's so unique, it's so different from other, you know, virus. To think that in jig time they could have managed to get a vaccine that was somehow going to have that impact, you know, to prevent you having it or for it to be less of an impact. I don't know, I'm very, very sceptical about it. I know people who have not had the vaccine and have had COVID and it's been slight and they've suffered, you know, they've had conditions like diabetes or whatever. I know people have had all the vaccines and have had COVID, which has hit them like a ton of bricks. Who knows? I certainly, as I said, I took 2 vaccines. I wish I had never taken it at all. And if I was offered it again, I wouldn't do it. I think there was an awful lot of pressure. Although I don't believe it was mandatory, certainly there was that feeling of, you'll be taking the vaccine, well, you'll not be going here, and you'll not be going there, and you'll not be flying. It could be an element of you losing your job. All of this was an undercurrent going on.
That
No,
was the
it's
next.
kind of veiled threats towards what will happen if you don't take the vaccine.
That was the next thing I was going to ask you about, because you make reference to that at paragraph 66. And I think I don't need to ask you to repeat what's in paragraph 66. Those are all the questions I have for you, unless there's anything important that you think I haven't covered. Ms Napier, thank you very much.
Thank you.
Yes.
My lord.
Thank you, Ms Napier. Very good, and thank you, Ms Caskey. Now, Ms Caskey, we finished earlier again, which is, this is not a criticism, relatively common. I don't know if the next witness is here, actually.
Nor do I, but I'm sure the usual channels will be in touch, if I can put it that way.
Yeah. If it's possible to start earlier, we can start at about 10 to or something like that. But if not, we'll start at 11 o'clock. Thank you very much.
And I will see you this afternoon.
So I believe. Thanks. Good morning, Ms. Barami.
Good morning, my lord. Our next witness this morning is Maurice Hickey, who's Scotland Head of Policy at the Pharmacists Defence Association. And his statement reference number for the record is SCI WT 0333-501.
Good morning, Mr. Hickey.
Good morning, my lord.
Right, if we're all ready, Ms. Barami will have some questions for you.
Thank you, my lord. Mr. Hickey, please could you tell us briefly about your own background and about the Pharmacists Defence Association, please?
My own background is that I'm a pharmacist. I've been a pharmacist for 42 years, and over that period I've worked in all the sectors of pharmacy, and I've worked as an employee, I've worked as a contractor pharmacist, and currently I work as a local man for the trade union. I've also been active in pharmacy politics over most of that time, and basically have sat in every board at some time that you can get elected to, including the board of the Royal Pharmaceutical Society of Great Britain. I worked for the PDA partly because of COVID. I just got, by 2021, I got to a point where I'd had enough, basically, and wanted out to a certain extent. And the PDA had started to restructure as a result of COVID, and were sort of changing the way they operated in Scotland. The PDA is the largest representative body for pharmacists. There's roughly 65,000 registered pharmacists, and we represent, as members, 38,000 of them. We're the largest such body in the British Isles at the moment. Roughly 10% of our members are in Scotland, and the PDA is a trade union. It's also a professional indemnifier, and it's a membership organisation, so we try and look after them, and it is only for pharmacists. It's not for other pharmacy staff. We we challenge employers, regulators, and government on behalf of the members, and we look after the students from the day they start at university. We offer them free membership. That's it, basically.
Thank you. Now, when the pandemic restrictions were put in place, many pharmacies saw a surge in workload, while some saw a significant decline in patients and customers. Would you tell us the reasons for this, please?
The reason was because of the lockdown. If you worked in a city centre pharmacy, a lot of cities are not like Edinburgh in the sense that they have a lot of people living in the centre. A lot of cities have business areas or whatever, and all these people vanished to home work as a result of the lockdown. I mean, I was doing the odd day very close to here, and what we found was our patients changed overnight. It was all the ones that lived nearby that we started seeing, where previously they would have gone to pharmacies near where they worked during the day. I think some of the pharmacies were around railway stations, for example, and in the more sort of business-orientated areas, their clientele vanished overnight, and it took a number of the companies that controlled these pharmacies. They were mainly chains, but I think it took them several months to sort of adapt to that. So, and the other side of the coin was that in the sort of more outlying areas, these pharmacies became busy because of that, but we became much busier as a result of the general lockdown. But this change between the city and perhaps the suburbs was quite profound.
Yes, thank you. And that led the busy pharmacies to implement a one-in, one-out queuing system. Did that lead to issues with some patients, particularly in the winter months?
It led to issues with some patients from the word go, but by and large, people accepted it. Certainly during the first lockdown, you have to remember that pharmacy, when you go into a pharmacy, the bit that the patients go into, it can be quite a big area. and there's a bit behind it that patients are excluded from, and it's much smaller. And in many cases, we had to sort of move forward in the shop, and to have two people queuing in the shop, that caused problems, and you were, everything had to be done at the counter. So, for example, if we were dealing with people that wanted to come in for a urinary tract infection or to get the daily supervised methadone, we couldn't take them into our consultation rooms. That had to be done at the counter, and these are quite tricky interactions to manage if there's a queue in the shop. So very quickly it had to be one in, one out. So when the patient came in, it was just them and whoever was there, which led to a lot of people thinking that not much happened in pharmacies because they're used to them being quite bustling places. But I mean, in actual fact, there was a lot going on, and if there'd been things go wrong, patients wouldn't be aware of that.
Thank you. In paragraph 19, you state that a number of GP surgeries were doubling prescriptions to ensure customers' patients would not run out. For example, instead of 4 weeks' worth of prescriptions, they were issuing prescriptions for 8 or 12 weeks at a time. This also contributed to subsequent shortages of medications, particularly devices like asthma inhalers. And later in your statement, you also speak about people stockpiling over-the-counter medications such as paracetamol, which also led to a shortage of that medication, and in time, people stockpiling lateral flow tests. Firstly, did that ever result in medication expiring before it could be used, and so leading to waste?
I don't think anyone can say for certain if it would have. Generally, if in a pharmacy, if you're given a prescription and it's longer than the expiry, you're given enough until the expiry date, and then you're asked to come back. That in itself was, particularly for some of the COPD inhalers, was one of the sort of issues that caused patients to become, shall we say, agitated, because they weren't sure if they would get the second one, and they were always aware that there were shortages because it was widely publicised. In terms of I think the idea of issuing 4-week prescriptions, there's quite a lot of evidence that suggests that if you issue 8 instead of 4, there is more wastage. So it's it means more work for some people, but now it's all computerised, it's not so difficult. But a 12-week prescription, there's considerably more wastage because people don't always need it, and and people were ordering things they didn't necessarily need because they might need them, and that would be medicines for stomach problems and whatnot, where depending how they eat or different factors, they would not necessarily need a month's worth for a month, but they were coming in and getting as much as they could, and you felt it was always because it was what if we run out of things. So that was an issue. In terms of the overall waste, I don't think anyone's documented it, but something I've discussed with colleagues and we noticed was that we gave out huge amounts in, particularly in the first lockdown. This didn't occur in the other ones because the health boards leaned on the doctors to go back to normal prescribing and everything settled down. But in the first lockdown, we discussed that with colleagues, and we would say, well, that means they don't need it the next time, 2 months' time or 3 months' time, when they're because they've had it when it's due, but they would still come in. And I looked at a few records myself, and I know others did, and it would seem that a lot of that must have gone to waste.
Thank you. And it might be that GPs were pressured by patients to double and triple prescriptions, but do you believe that there would have been the same level of shortages if GPs hadn't prescribed in that way, and if individuals hadn't chosen to stockpile over-the-counter medications?
I mean, sadly, shortages are with us all the time. It's a major part of my job, major part of any pharmacist's job. But I do think that there was a shortage of paracetamol, for example, and was a shortage of COP, drugs that had an effect on breathing, inhalers and the like. And I think the fact that people were overprescribed probably for about 6 weeks from the onset of the lockdown, that contributed to it, and it took the supply chain several months to settle back down. Certainly once we got into the second lockdown, the third down, I would say, well, yes, there were shortages, but not really significantly more than I would expect at any other time. I mean, if it happens to you, if you're the patient, it's not good news. And the shortages are very often in drugs. I mean, you can't say to a diabetic, well, I'm sorry, we can't get your insulin. That involves changing the therapy. That involves other practitioners. There's all sorts of things reinforce it, but generally the shortages that we hear about are the, shortages of painkillers, shortages of insulin, shortages of drugs for people that have difficulty breathing, and these are all worrying for patients.
If a patient with diabetes or COPD, issues like that, health issues like that, wasn't able to get their medication, would there be a risk of them having to be admitted to hospital to be managed in a different way?
There's always a risk. With every patient, medicine is not a risk-free supply function. There were difficulties certainly then with making communications with the surgeries. We would refer them to minor injuries, minor ailments, or to casualty if we thought fit. But generally, we would try and get them to make contact with the doctors, and we would contact the doctors and say, "Look, there's a problem with this." There's a process. It's not perfect, but I don't think that particularly failed. I think some patients got quite close or quite stressed by the situation, and I think if they were admitted to hospital, it was because there really was nothing else that could be done. If they could be managed at home, they were managed at home.
Yes. And did the PDA ever try to raise the issue of prescriptions with double and triple the amount of medication, or issues of stockpiling by individuals with the Scottish Government?
I don't think we raised it in particular, but I'm pretty sure some of the other bodies did. It was well known as soon as it happened. I think a lot of pharmacists complained to the health boards and said, "Look, we can't manage this situation."
Was there a view that either the government directly or the health boards should have stepped in sooner to prevent this becoming an issue?
I don't really know what they could have done, because to be perfectly honest, it happened so quickly, and they did act. I mean, perhaps they didn't act as quick as I would have liked, or as a working pharmacist I would have liked, but they did act. Having said that, there are professionals that will do as and what they please. I mean, that's true of all the professions, not just the medical ones. But generally, once the health board sort of were alert to it, I think the things start. We went back to having normal shortages.
Yes. In paragraph 21, you mentioned that pharmacists also took on a triaging role during the pandemic. Would you tell us about that, please? Well,
that was partly because the doctors, it was very difficult to see a GP. Having said that, some surgeries were better than others. The very worst, I think, would be that the receptionists, not the doctors, were just telling everybody, if you phoned the doctor, you were told to go to the pharmacy, and we would see them the next day or the same day. And basically we had to triage them. A lot of them we could treat, it has to be said, but a lot of them we couldn't, and we had to, there had to be local mechanisms in place to refer them back, and some surgeries were good at handling it and some were bad.
And that also increased your workload further?
It hugely increased our workload, because you've got your normal workload that you do, and we're very busy as a rule. I mean, I suppose the best thing about pharmacy, in a sense, is that there's no appointment system. Anybody can walk in, anybody can access, ask to speak to the pharmacist. If anything, the queuing helped in one way, but on the other, a lot of the people we were seeing, we saw all sorts of people would just come in, and you almost thought they wanted out of the house if it was an excuse to get out of the house, and I wouldn't blame them. I mean, I didn't know what it was like to be banged up for 6 months because I had the opposite problem, not being able to be. But I think the triage system, some surgeries, the receptionists just were told to send everybody to a pharmacy, and that considerably sort of increased our workload on top of what was already a huge workload that many of us, our surveys, the PDA surveys, the Safer Pharmacy surveys were showing in 2017, 18, 19 that there was in parts of pharmacy there were incidences of burnout in the 80% range, and COVID just blew that out of the water. Everybody struggled.
Can I ask, please, this increase in the use of pharmacists for triage purposes, did that cease, go away, go back to what it was pre-pandemic when the pandemic abated and went away?
No. We have you'll have heard of the Pharmacy First system, where we can supply counter medicines, and we get paid. The consultation we get paid 3 ways. It's the same payment that you get, but we can give the patient advice. We can supply medicines, or we can refer them to the GP surgery. And Pharmacy First was relaunched in 2020. It was meant to be relaunched in April, and they postponed it to end of July, beginning of August, which increased the education burden on pharmacists in the midst of the first lockdown. But the Pharmacy First system, in many ways, is a triage system. So you have 3 choices, one of which is to send the patient to the doctor. And I think the usage of the system, there's 2 million patients used it in the first 15 months or so. It was widely popular, and it continues to be the same. If anything, it's busier as more and more people are aware of it. So that triage system was in place, was heavily used, and is still heavily used, but it's structured differently now. It's one of the positives.
Thank you.
Thank you. We've heard from a number of other professionals that there were great feelings of stress, underappreciation. Mental health was severely impacted, and there was a lot of burnout, and people were leaving their professions early. There was a sense that they were seen as separate to the NHS and not appreciated like NHS staff. Were those range of feelings and actions also true for pharmacists?
It's widespread. I mean, when I read through the union did it, the PDA did a lot of surveys, including the Safer Pharmacy survey, and when you read that, it just comes out the page in neon that everybody felt like that. And pharmacies, community pharmacy particularly, is a bit different in that it is part of the NHS, and we deliver NHS services, but the pharmacists that work there and the locums have no access to the NHS pension. They're not on NHS pay scales. They don't have the career structure that you have with band 5, 6, 7, 8, 9 in the NHS. So everybody feels slightly divorced, and I think, particularly in the case of that group, the feeling of being isolated and excluded was and there was other things happened, but that feeling was magnified, if anything. And I remember at the beginning of the thing, we were told to stay open, and there was a letter came around saying if you get ill, contact public health, and they'll tell you if you can go to work. I knew one pharmacist who worked in pharmacy who, they were in an area of Edinburgh that had a lot of tourists, and there'd been lots of the rugby players who come to the area, and he got ill with what in retrospect was obviously COVID, but when he phoned the public health, they said, "You've got the wrong symptoms, go to work." And you know, you have to say, on the other hand, I don't think they knew how it was developing, but there was more than one instance like that. It was always a problem, and then I think initially there were difficulties with many of the pharmacists getting the communications that were coming from the government, coming from the contractors' body. It's Community Pharmacy Scotland. Both sets of communication was very good, but because of their position as employees of contractors or subcontractors to contractors, a lot of them didn't see the information coming out initially, and it was that was made worse by the fact that they changed the operating platform that the NHS email system works on, and a lot of people like myself who had an I'd had an NHS.net email since about 2005, and all of a sudden they changed to NHS.Scot, and I couldn't get one because they had problems that meant you had to be fully integrated into the NHS to get one, and they would allow one person in a shop, I think, to have the email initially. They've got that sorted out now, but I know that was, having spoken to government officials, that was a problem also for some of the other professions, locum dentists, locum optometrists, and people that were peripatetic, all had difficulty getting the emails and accessing information.
And there was also an issue regarding low-paid pharmacy staff moving to other, leaving their jobs and moving to other roles that were deemed less stressful.
That's always been an issue. The pharmacy support staff, I mean, at the moment, the government or the DHSC in England have put through national protocols to allow technicians to take on some of the work in community pharmacy under PCDs, but the employers aren't training as many staff as they can because they pay them so poorly that as soon as they get them traded, they'll go into the NHS because they can earn a third to half as much, and they have a career structure, and they get the pension, and they have to work less hours, and they don't have the stresses that they get in community pharmacy. That's always an issue. And all of us in community would work with support staff who are trained, they're technicians, they're regulated, who would leave and get more money stacking shelves or sitting on the till at Lidl. And that's something that doesn't affect the pharmacist, other than the sense that we don't have properly trained support staff surround about it. But I mean, you can't blame anyone for leaving, especially the way we were getting treated by patients, by management, the way we all felt ignored. I would have done the same.
In paragraph 27, you state that when people became ill with COVID-19, while larger pharmacies could move staff around, smaller pharmacies at times had to suddenly close the whole pharmacy. Did that, in those areas with the smaller pharmacies, did that lead to patients not being able to access medication that they needed?
I think there was odd instances, but I don't think that was particularly a big problem. I think initially the larger chains were reluctant to move staff about, and then did. I think in the case of the smaller chains, there's probably a problem in the sense that if somebody in a particular pharmacy contracted COVID, then they all had to isolate, and that meant there was maybe one or two staff that were normally there who hadn't been exposed who could go back to work. So they would have to move staff from other shops, and that would spread COVID around the group. And I know a few of them were affected by that. the single-handed independents, which are vanishingly rare these days, to be perfectly honest. I think they had, everybody had problems, but it was just dealt with at the time. And I think there was a lot of sort of thinking on the foot and maybe minor breaking of the rules, because it was the only way we could work.
Thank you. In paragraph 30, you tell us that pharmacy owners in Scotland were paid specific funds to provide training to their staff. Was this payment made by the Scottish Government?
Every payment that the pharmacists get is paid for by the Scottish Government. I mean, the average pharmacy, one or two of the big chains who have large shops might be different, but the average pharmacy, the split is 90% of their funds or their payments come from the NHS and from the government, therefore. The other 5% is just counter sales, and it's a diminishing amount, especially with Pharmacy First, when people know, well, why would you go and pay for something when you can actually endure a 2-minute consultation and get it for nothing and save a tenner? You would be mad not to. So all their money comes from the government. Within that money is included, in current terms, they get paid for staff training. That's not just for pharmacists. A lot of it is, it's for all the staff, and it's to cover things like Pharmacy First, new PGDs, that sort of thing. The government, the civil servants tell me that the spirit of it is that should be spent on the staff, but as a union, we survey our members and say, do you get protected learning time? Do you get time off? And the truth is, most of them, and I don't mean like 80%, but a very high percentage of them do not, and they have to do it in their own time. Now, that was a major problem in 2020 when the Pharmacy First minor ailments scheme was changed to Pharmacy First, and there was a lot of training to do with that, and there was a subsequent train of PGDs where we would supply antibiotics for skin infections. We could treat herpes, a number of things. Shingles is the word I was looking for. They all had to be done, and people had to do them at the time. And this was at a time where they were going into work, and although we were working less hours as far as the public could see, because we wouldn't open till 10, we'd close for lunch, and we'd close at 4:30, and that would be for cleaning. Most people were just trying to catch up with the day-to-day work. Many people were working longer hours, unpaid, and then they were being expected to sort of undertake this burden of training in their own time, often at weekends, and that should have been family time. The employers, by and large, did not pass that money on to the staff.
Do you think the organisation that paid each pharmacy should have held them to greater account for the purpose to find out what they were spending the money on, so rather than just releasing it, expected them to account for what it had been spent on?
I think there could be better audit of how the money is spent and how, where it goes. The simple truth is, if all the staff do it in their own time, then the contractors can say to the government, everybody's done it, and that's, so the system works. But the system's working at the expense of the staff now, of burnout. That's true for all the staff, and I mean, that's something I would like to see would be better audit. I think there are different ways of doing things, perhaps directing that to the staff, and I think you could see that in COVID. It became a particular burden.
Thank you. Now, we've heard from a number of other professionals as well that they couldn't access furlough funds, but also couldn't sustain themselves on statutory sick pay, so had to work even when they were ill. And in some cases, professionals were self-employed and so didn't even receive sick pay. Was this also true for pharmacists and pharmacy staff, and did this contribute to people leaving the profession?
It must have contributed. It was a major problem. I mean, I don't think people necessarily left during COVID, but I think that there's been quite a lot of people left since, and I think that's a significant issue. If you were a locum pharmacists, if you didn't work, you don't get paid, and they were classed as self-employed business people. They didn't get any furlough, and they don't qualify for statutory pay. And I do know pharmacists that work longer than they should have, and especially now we know about things like long COVID, and that's acknowledged. People did go back to work sooner because they sooner than they really should have, and at the end of the day, people have to feed their kids, they have to pay the mortgages, and you can't really blame them for that. In terms of the staff, I think that's a new pharmacy staff that had been furloughed, and they were people that had particular health issues. But the bulk of pharmacy staff did go to work, and for staff who were employees and took ill, they only got statutory sick pay, and a lot of employers within the sector don't actually add any more than that. You get it now. I couldn't live on £80 a week or whatever it is. They had colleagues who were furloughed right through the lockdowns and the whole period, who were getting 80% of their wages. And the people that we heard from people, I heard it myself, staff saying, I'm not testing myself for the pure and simple reason I can't afford to be ill. If staff that got ill, because we were very exposed to COVID, everybody got ill at some point. If we'd been able to get equity with people who were furloughed when we were ill, which I think would have been only fair, I think that would have gone a long way to decreasing the sort of incidences of long COVID. People wouldn't be so burned out, wouldn't have been so ill at the time, and it probably would have reduced the spread within the shops, because I think people went to work when they knew they had COVID, and people certainly went back to work earlier than they should.
Thank you. We've heard from care homes that UK-wide care home chains often attempted to apply English guidance in Scotland. And I see from your statement that this was also an issue for pharmacists. And you give an example of that in paragraph 41 as staff being able to go to work if they had COVID asymptomatically in England. But in Scotland, that wasn't permitted. But UK-wide pharmacy chains were requiring Scottish staff to be at work in accordance with English rules. And when the PDA contacted them about this, they refused to change anything until Hamza Yusuf spoke to them. Was there a regular need? Did you find a regular need for the PDA to intervene in these situations?
Yes, there was, at certain periods. I mean, the issue of mixed messaging, where the media were reporting things has been in Britain, and this was more of a problem, I think, in the first pandemic. Everybody got wise to it and would counteract it when it happened later on. But the mixed messaging that was coming out, and that affected patients, not just pharmacy staff. I mean, some of our staff were confused because the higher management, particularly in the chains, were telling them one thing, and they were phoning us up and saying, "Is this right?" And we say, "No, that's England only," or it's England and Wales. This is what you have to do. So we would put out press releases and say in Scotland, and or qualify it and say, this is the situation in England, and then underneath, and in Scotland and Wales, it's different. The incident you're referring to is one of the larger chains, and I think it was in April 2022. The superintendent issued a statement to all his shops saying, if you feel well enough, if you've got COVID but you feel well enough to go to work, go to work. And that didn't apply in Scotland, it only applied in England. And we wrote to them within 24 hours of them releasing it, because as soon as they'd emailed it to the staff, we had people phoning us up and sending us WhatsApps of the actual letter and saying, isn't this wrong? We contacted the company and they just said, we don't care, you know, we just treat all of Britain the same. And we continued to put pressure on them. So in the end, I contacted the medicines division in St Andrew's House, and it was escalated to Hamza Yusuf's office, and he made a statement saying it's different, and they had to retract it in Scotland. So it was always an issue that affects pharmacy, that quite often though the chains, and you can't really blame them in a sense, you know, 90% of their pharmacies, this is the model, and then Scotland's 10%, and it's a slightly different model, and they work on a one-size-fits-all, or they try to work on a one-size-fits-all model. It wouldn't be a problem with the Scottish chains or anything. It was specific to the UK-wide chains.
So essentially the mixed messaging is a result of management making a decision to ignore Scottish guidance and apply English guidance where it shouldn't be applied?
I don't think they ignored it. I don't think they were aware. You know, they look at it from an Anglocentric point
Do you
of
think
view.
they had the resources to be aware of the different...
They had the resources. I mean, they've got much more resources than we have as a member non-profit organisation which relies on our members to give us our income to represent them, and we could cope with it easily. We had all sorts of checks in place, so you know, we knew. So if something happened in Scotland, I told everybody. My equivalent in Wales did the same. I knew what was going on in Northern Ireland, Wales, Scotland. Sometimes I would see something happen in Wales and I'd be going to lobbying the government saying, you should look at this, this works. So if I can do it in 3 days a week, I'm pretty sure that a large multinational with, you know, their kind of money could do that, and their staffing levels, they could have done it. Weren't interested.
Thank you. Another significant cause of concern for pharmacists and pharmacy staff was the inability to socially distance in smaller pharmacies, and that was exacerbated by a lack of availability of PPE. Were pharmacies being provided by PPE by the NHS, or were owners purchasing their own PPE?
3 stages, I suppose. I mean, the current conditions in pharmacy, that's something I'd like to go back to, but the problem with PPE, I think it was 3 stages, possibly 4. Some pharmacies had PPE, really just because they provided certain services, or because they had a client base that asked for it. I wouldn't say it was widespread, but I certainly worked in one shop who had PPE, and it all disappeared overnight in late January, and we all laughed about all these Chinese people, for want of a better description, coming in and buying all the masks. And it was because COVID was happening at home, and they responded to that, and very quickly we ran out of it, much to shock, and tried to reorder it and couldn't get it. The first main stage, it was being supplied through the health service, the health boards, and we just didn't get it, or if we did, it was very, very limited. Some pharmacy owners did obtain it because we're quick off the mark, but they didn't, I think, get very much. And very quickly, nobody had any, so we were left sort of out there. Hence the fact that in a lot of shops, people put screens up as quick as they could. Not all, it has to be said. So it was coming from the health boards, and there was very much a feeling amongst our members that we were last in the queue. And now that could be, in the case of community pharmacy, that could be because we were not seen as part of the NHS or a full part of the NHS, but we also had hospital pharmacists reporting to us that they weren't getting as much, and they certainly weren't getting the better PPE. They were just getting the simple mask, if they got anything at all. That was resolved when the government managed to put the supply through the pharmacy health, through the pharmacy wholesalers, and we were able to order it from them. And by the end of the year, it was pretty widely available. You didn't always get it. You had to order it every day. So you would order, you might need a box for a day. So you would order 10, constantly trying to keep ahead, because there were, at times, we just couldn't get it even then. And it sort of, into 2021, it became normal. But there were 3 stages. The employers, some of them, tried to supply it. Then it went through the health boards, and it was very sort of, you couldn't predict that you would get it. And then it went through the drug wholesalers. So it came with our daily drug deliveries, and that solved the problem. I think that's a lesson that was learned quite quickly, and I think if were ever in that position again, I can't see that they would do anything differently. In terms of PPE, though, and again, this is in the first lockdown, there was so little in the place. There was a lot of people would wear throwaway PPD. The government was saying there was. I'd hear in the radio, John Swinney or Hamza Yusuf or Jean Freeman saying, "There's loads. Everybody's got it. We've got it in place." And I'd be thinking, I haven't seen any, and there would be people phoning up in Radio Scotland and saying, "I'm phoning from a surgery and we don't have any," and so forth. People had to reuse it, and the guidance was that if you used it and took it off, you should use another one, a clean piece. I saw drug delivery drivers who were going out into the community and driving around patients, and they were using one piece for 2 weeks. You could tell how long they were wearing it because it bobbles and it looks dirty, and people were making homemade covers to put over them, and you'd be saying to people, you really shouldn't be wearing that. You know, it was a non-ideal situation, but I think we were where we were at the beginning, and I think by the end it was all the problems were ironed out, but it was badly handled.
And in paragraph 50, you state that even when PPE was available, some pharmacy owners discouraged or prevented staff from wearing PPE because you say it set the wrong sort of image and was not attractive.
Yes, yeah. We had
What was the PDA's views about that?
Well, we were so concerned about some of the things we were hearing, and some of the things that were being said, that because it's a retail business, I think there was a feeling that some pharmacy owners put commercial imperatives before, if you say, clinical imperatives. That had several impacts, but at the beginning there was a lot of them were reluctant to put up screens. A lot of them were reluctant to have their staff put masks on because they thought it presented the wrong image. It may be that, I mean, some of the managers making these decisions were not medical staff or medically trained in any way. And it may be that they just hadn't quite grasped the seriousness of the condition, but that happened in several places, and we produced a risk management book. I refer to it in the report, and we sent that out to all our members and said, this is what your pharmacy should be doing, and they could work through it, and that enabled them to go to employers. But there was nothing came from the government or There was a certain amount came from the contractors body, Community Pharmacists Scotland, but nobody, I think, other than us, produced a proper risk management tool so you could say, if this is happening, you're in danger. I mean, some of the risks you couldn't eliminate because of the size of pharmacies. I would say more than half of them, to actually socially distance was impossible. I mean, you're in a small space, small room, and you're having to move around all the time, and everybody's moving around. And we all joke that at some point in the day, everybody in the pharmacy will be standing the same 1 metre square. You're bumping into people, people are coughing, people are ill. Nobody saw that because they were on the other side of the counter, and they didn't necessarily see into the pharmacy space where we were working, and that was a problem.
Did the PDA try to contact pharmacy owners that wouldn't allow their staff to wear PPE?
Oh, we do that routinely. You know, for people phone us up with, it can be, I didn't get paid for my locum, and we just phone up the office and say we're the PDA. It gets solved very quick, and the same goes. We did that with the large chain that was given the English guidance in Scotland straight on the phone to them. We do that as a matter of routine. If a member phones up and they've got that sort of query, we've got people who just get on the phone and say, is this right? And if it is, don't do it.
Yeah.
And if they don't do it, we pursue them.
And in respect of preventing staff from wearing PPE, was there a view that the regulator or NHS Scotland should have stepped in to enforce the requirement to wear a mask or other PPE?
I think the regulator would take the view that they couldn't enforce it because it's not within their remit. And I think the government would probably say the same, because they can't actually force people to do something unless it's in legislation. It's the same for the regulator.
So do you think the government should have enacted legislation preventing employers from preventing their employees from wearing PPE?
It would have to have been emergency legislation. Part of the problem was everything that came out was guidance, and some people, and it happens all the time, some people will push the envelope, as they say, and ignore the guidance. And this was a case. I also think that in many cases it was just people that weren't medically trained, who were in charge of medical functions, completely misunderstanding what they were having to manage. I mean, it does beg the question that are these the most appropriate people to manage health professionals, health functions, and things that impact on patients?
We've heard from some professionals that they suffered higher levels of verbal and physical abuse. Was this also the case for pharmacists and pharmacy staff at times of shortages and queuing and the like?
Absolutely, categorically, yes. It was horrendous. Everyone, if they didn't experience abuse themselves, witnessed it firsthand. I think we did a survey and we found that something like 60-70% had actually experienced it. Now that could be verbal, but nearly 100% of our members, when they were surveyed, said that they had witnessed or suffered some abuse. Now that can range from just people being sarcastic and just generally shitty, for want of a better word, right up to full-scale assault, and that happened. People picking up things in the shop, throwing them around and whatnot. The problem with that, from public perception, was nobody was aware this sort of thing was going on, and it happened all the time. It's not most patients didn't cause it, but if you say 95% of patients are wonderful, it's the 5% that cause you all the bother that stick in your mind and affect your mood at the end of the day, because you know, your adrenaline gets going when you're in that sort of situation where there's a confrontation like that. It's not good to experience, and to get it day on, day out, was particularly bad in terms of everybody's mental health and so forth. You used to dread going to certain places because you knew what they were like. It was just constant. I mean, we've got one of our senior reps. She was held up at knife point. We've also got a lot of members who are black, minor, you know, ethnic community pharmacists, and they suffered a lot of targeted racist abuse. You know, and it could be things as simple as we've had to order that in for you, especially, and it'll be here tomorrow. And you're just standing there and there's somebody acting like, you know, it's the Texas Chainsaw Massacre, and you know, and it goes like that. That was what I think most people struggled with. You never knew who was going to do it, and you never knew when it was going to happen, but it did.
Thank you. And you touched on it there, but in paragraphs 84 to 91, you talk about issues for BAME workers and other disproportionate impacts. And in paragraph 85, referring to BAME and female pharmacists, you state both groups were shown to be worse affected in a number of ways during the pandemic. Could you tell us what some of those issues were and whether you consider anything could have been done, particularly by the Scottish Government, to alleviate those issues?
I think we weren't the only people to raise it. The UK Black Pharmacists Association and I think at other times the Royal Pharmaceutical Society raised it as an issue. The factors that affected female pharmacists were there's more female pharmacists than male pharmacists, and there is a very high proportion of our workforce that is BAME. They had problems at home with their families and so forth, and their communities. But in terms of being at work, they were an easy target for people that were stressed. So somebody that is just freaking out generally, they would be the person they'd pick in the room to unload on, because if they did it to me, I would give them it back. But they would think that, you know, the little girl in the corner, she's not going to talk back to me. And there was a lot of bullying, and it was just sort of, it just became endemic and constant, and it particularly affected them. And as a group, the government's producing, the English government, or the Westminster government rather, was producing evidence to sort of say that quite early that these groups were actually more prone to, maybe because of the way that their living conditions or where they lived in cities, they were more prone to getting COVID. And I think that preyed on their minds as well. You know, so you don't need to go into work and then be picked on further when the disease seems to be picking on you. We certainly raised the issue very quickly with I think it was Christine McKelvey, MSP, who was I think it was the Equalities Committee or something like that she was convener of, and we followed it up. But it was just something that was there. It applied to all pharmacists with protected characteristics. There was a lot of abuse towards all pharmacists, and I mean myself, I have a hearing disability as a result of a car crash many years ago, and I would get it off patients. They would be saying things to you like, "Are you deaf?" And I'd pull out my hearing aid and say, "Yes." You know, "Can you speak up?" And then they'd start shouting their head off at you. All the screens that made the situation worse for lots of people. made it worse for a lot of patients with the similar disabilities. But in terms of the BAME pharmacists, I think our surveys and the UK Black Pharmacists Association surveys would appear to say that they got more of it, or they were more likely to get it, and more of them are female. If that answers your question.
Thank you. In paragraph 111, you state that while usually a pharmacy can't dispense medication when the pharmacist is absent, the regulator permitted a specific time-limited dispensation where no penalty would be applied if in specific circumstances ready assembled medicines were being collected by patients in the physical absence of a pharmacist, but there was a requirement for a pharmacist to be available by telephone during that short period. You say, however, that almost immediately corporate pharmacy owners started taking advantage of that relaxation, and in paragraph 113, you state that these companies attempted to run some pharmacies with no pharmacist present at all, while requiring locums to have to manage multiple pharmacies by telephone. What issues did that create, the lack of a pharmacist being there and locums having to spread their attention across multiple
the first factor that increases when the pharmacist is not there is there's an increased danger to the patient because there's no pharmacist to consult. That by its very nature is the primary danger. This issue arose partly, and I think the dispensation from the GPHC, General Pharmaceutical Council, who are the regulator, I think the dispensation arose because you did have situations where a pharmacy would have to close and there would be medicines there that were bagged up, ready to go. So it was really to ensure that patients still got the medicines while in this space, while the pharmacy got sorted out and got cleaned, got reopened and so forth. So there was that. But very quickly what we found the employers were doing was they were saying to their staff, would you be able to cover 2 shops? You can only have 1 responsible pharmacist per pharmacy. You can't be responsible for another one geographically distant, even if it's 30 yards up the street. And what these particular companies were saying was they would say to the staff, can you cover that other shop? We don't have a pharmacist there. And they would say there's a shortage of pharmacists, or they would book a locum and say, but we want you to cover 2 shops. Now, saving on the pharmacist's salary is a significant salary if you can do that. That was a commercial decision because there was in fact no shortage of pharmacists. And the reason I can say that is that in the lockdown, people didn't take holidays because who would take a holiday and sit looking at 4 walls at home when you can at least get out? By and large, people just worked. Particularly in the lockdowns, and then had their holidays after. So we had complaints from members who were locums who were saying, I'm having all my bookings cancelled. And then we were finding out they were cancelling bookings and the shop wouldn't open and they would operate differently, and they would say, the companies were saying, there's a shortage of pharmacists. Well, there was this pool of locums who were no longer able to work because their bookings were cancelled, and there was also the fact that I think they took 3,000 retired pharmacists onto the register. So instantly there was a pool of thousands of pharmacists who could work in all sectors, and there was no shortage. And these companies were trying to run 2 pharmacies on 1 pharmacist. So we very quickly, the union very quickly lobbied the health departments. They didn't seem so interested, it has to be said. And the regulator issued a statement saying, you can't do this. And I mean, it affected our members, but the major reason was the most dangerous thing you can do with the pharmacy is run it without the pharmacist. The last check's not there, which is when the patient comes in and you speak to them. You know, the number of times that you say, have you got any questions? Or they'll come in and present and you look at them and you know something's wrong. Take that away. Or there's nobody to explain how you take your medicine. They always say in our profession, if you really want to scare yourself, tell a patient something and then ask them what you've just told them. And it is scary.
Yeah, and when the regulator issued that statement, did that put an end to the practice, or did some continue?
It put an end to that practice, although I mean, even to the current day, we see instances of it, and again, it occurs with the chains where on a Saturday they'll try and get somebody to cover 2 pharmacies, and they'll cite the fact that they can't get a locum. We have instances then where we recorded they closed pharmacies and locums had offered to work at reasonable rates, and they said no, we just decided to close, and they still get paid.
Yes, I wanted to ask you about that actually. In paragraphs 124 and 126, you speak about that they corporate pharmacies chose to close temporarily rather than pay for locum pharmacists, and that they were still reimbursed by the Scottish Government for services they were either unable or unwilling to provide. And you contrast that with the situation in Wales, where they would not be reimbursed in that situation. And is it the view of the PDA that the Scottish Government should consider the Welsh position and consider declining to pay in that situation, in the hope that it would lead to a decline in the rate of closure?
If I can explain it, the way they get paid, they negotiate every number of years a different contractual framework for the pharmacies to get paid, pharmacy owners to get paid, and they get paid all sorts of different kinds of payments, which loosely can be split into 2. Activity payments and non-activity payments, and an activity payment would be one that you wouldn't get paid for if you're not open. That's dispensing, supplying medicines. Now, if you close for 1 day and 6, generally you'll displace them into the other 5 days, so you have 5 days where you're busier, and you get all the activity payments. The other ones where they get paid for supplying services, like public health services or whatever. But and it also includes things like the education payments that we were talking about earlier. There's a whole variety of them, but they get paid. They get paid them regardless of whether they don't open. And we've estimated they could be worth between £400 and £700 a day. So there's a significant saving that can be made by not opening the pharmacy and displacing the activity work into their other hours. We have lobbied the government, the Scottish Government, and been told that it would require legislation to change that. And that can only be done when the next contractual frameworks negotiated, which will be in a few years, probably 2026. So we would hope that we can get something put in place. The Welsh situation was that when they negotiated the contract, the government in Wales slipped it in that if you don't open, you won't get paid. And I don't think the contractors thought very much about it at the time, because if they could prove there was a good reason, your shop had been flooded, or you were in a rural area and somebody couldn't, you had a period where you couldn't open because somebody got ill or whatever. These were fairly rare and never thought about it. And then of course COVID happened, and there was this knock-on from the contractors, the big chains where they closed, and we were monitoring the situation and finding there was increasing numbers of, they were abusing the situation in all 3 mainland British countries. and the Welsh Government turned around and said, you can't do that. We'll, you know, if you do that and you haven't got a good reason, we'll not pay you. And we'll take the money back, we'll recover the money. And the upshot of it was we had pharmacists from Scotland and England phoning up and saying, I'm being phoned up by so-and-so, and they're saying, can you go and work in Wales? So, you know, so it does work, and it can't work in Scotland because it's on the basis of an already negotiated contract that's in legislation, and to change it, they would actually have to bring in legislation in the current Parliament, emergency legislation, and I don't think there's a willingness to do that.
Thank you.
You're into your last 10 minutes, Ms. Barami.
Thank you, my lord. In paragraphs 130 to 145, you talk about pharmacists' involvement in vaccine sessions and that pharmacists took steps to prepare to contribute to the vaccine rollout in anticipation of the vaccine programme commencing, but they were subsequently excluded or given much lower rates of pay than previously agreed, while pharmacy owners were still paid the higher rates for supplying their employees for the rollout. Would you please tell us about that, including the perceived role of the CPS in that outcome and the effect on the rate of vaccination in the community?
Well, first of all, I don't think it actually affected the rate of vaccination. It was a technical thing, and it was something that we felt was very unfair. They asked for people to go and become vaccinators, and they were offering a rate of pay of £70 an hour. I think it was a 3-hour session that you did, and they made it open to dentistry, dentists, optometrists and pharmacists. Now, in the case of pharmacy, a lot of pharmacists are very accomplished vaccinators. I mean, I learned to I've been doing vaccinations since 2005, so have a lot of experience doing it. I'm not untypical. And what happened was they offered this, and lots of pharmacists immediately signed up, particularly locums who were able to do it, done the training, and couldn't get work because contractors weren't employing them. And very quickly, they turned around and said, no, pharmacists couldn't do that. Now, bear in mind, pharmacists were more experienced than the other groups, so where they started working, they were helping train the others. They'd done additional training in their own time, which cost money, and they had to take out additional insurance because they were doing COVID vaccinations and so forth. So they laid out this money to be able to do it, and then all of a sudden they were told pharmacists will no longer be able to apply for it unless they are they will be paid at the same rate as a band 5 nurse, which is, I don't know what it is, but it's about £18 an hour.
Yes, I think in your statement you say that the initial rate offered was £69 per hour, and that was reduced to £14.50 per hour. £14.50
at the time. Yeah, that would be correct. But what they had agreed with, I don't think it was Pharmacy Scotland at the higher level. It was at the local level, and this affected in particular Greater Glasgow. What the agreement they'd come to with them was that the pharmacy contractors could send a member of staff, and this member of staff would get paid £14.50 for the member. They would get paid £69. If a locum went, he got paid £14.50. If the owner sent a member of his staff, he would get paid £69, and he could book a locum at a lot less than that, and they made a profit on it. We complained to the government, we complained to Greater Glasgow, and Greater Glasgow sent a letter to us, which you've got a copy, saying that they had to take account of commercial imperatives, and they didn't want to increase the shortage of pharmacists, and they were worried that if all the locums, many of whom couldn't work because they weren't being employed, took on this work, there would be no pharmacists to work in the shops, and you think, this doesn't square up. So it was an abuse of a sort of position, and really it was something that was undertaken by people at the health board, I think, who were probably gaslighted in some way, to help the contractors made money out of it, and our members lost a lot of money out of it.
Thank you. Now, we have your statement. I'm just conscious of the time as well, and we will consider it in its entirety alongside your oral evidence today. We just have a couple of moments left. Is there anything you would like to highlight at this point that we haven't covered?
I think one other thing, very, very briefly, that we didn't cover was the £500 bonus payment, and this goes back to the fact that pharmacies or pharmacists in community aren't really seen as a proper part of the NHS. There's a sort of snobbery about it. First of all, some of the employers weren't willing to pass the payment on to pharmacists. They weren't willing to make the claim for their locums. And even in one case for their staff, because they didn't, couldn't be bothered. It was in Scotland, and they were a national chain. They weren't going to take that focus. We had set up a helpline for all the people that couldn't claim the payment. They were given, when it was finally agreed, after we'd lobbied the government, that it should apply to pharmacists delivering NHS services. Most people got the notification that they could claim later than they could make the claim, and in some cases they had, if you had 3 days at most, if the employer had already made the claim, they couldn't make the claim on behalf of you. So we had to set up a helpline and get all these people sort of listed, and it took up to 8 months after they paid the bonus to everybody else to get it for all staff, including people that were missed out because they were in maternity leave. And when they set up a portal, the government set up a portal to enable us to get in. They set it up, not everybody could get in because they had to give a contractor number where they had worked. This is a 4-figure number, and they were checking that you'd worked in all the places you'd claimed to make sure you weren't making an illegal claim. And if you worked in the health boards, or you worked for a hospital or for a GP practice, you couldn't make the claim, so we had to go back, and it went on. It was a classic example of how we as a group felt that we were in some way not felt to be part of the NHS, and yet we were the group that were open all the time. And if there's anything, I think I would like to see come out of this, that it's maybe that all pharmacists should be employed by the NHS, and the NHS can set health-based priorities for them. It's a bit like the Divine Comedy, and Dante arrives outside the gates of hell, and he meets Virgil, and Virgil, standing there, he's got all this knowledge, and he's the great philosopher, and he's got lots to offer. He can't get into hell, and he can't get into heaven. He's stuck in the middle, and that's a bit how I feel we were out in purgatory.
Thank you very much.
Okay, thank you.
Yes. Thank you, Mr. Hickey.
Thank
you. Good. 1:30.